But yeah, extra, yeah, an extra. So bad.
Good morning or afternoon, depending on where you are. On behalf of the Maternal Child Health here at NACCHO, I'd like to welcome you to the 8th and the very last webinar of our 2-year-long 8-part webinar series on continuity of care. Thanks for being here today, especially for the wrap up of the series. We really value your time here with us, and we hope you will leave our webinar today with some new insights and eager to advance continuity of care in your community. Our chat box will be open for about 30 minutes, so feel free to introduce yourself in the chat box, let us know where you're coming from. Thanks for also partaking on the poll. It's great to see that so many of you participated in many of the webinars on this series, and some of you participated in all of them. So thank you. And if this is your first webinar, you know you can go back and watch the recording and still receive continuing education for it. After we close the chat box, we're going to be available through the Q&A box. So you can ask your questions throughout the webinar, and we're going to have a Q&A session at the end. Here's our acknowledgement and disclosure. Our work is funded by CDC. The Blueprint is a collective intellectual work of a lot of smart people in the field. And finally, today's presenters have no financial interests to disclose. And then highlighted here is the answers of the most asked questions in our webinars. Continuing education credits are available, and the information will be shared at the end of the webinar. And secondly, the webinar is being recorded, and the slides and recording link will be shared with all registrants, and also will be available in our continuity of care website. So here's our agenda for today. We are really excited to have all these amazing panelists who have been advancing infant feeding data in their work. I like to say they're somewhat pioneers in this work, because recommendation 4 on data, working with data, is not usually the most popular recommendation that communities love to work on. I think a lot of us like to do our direct services work. We support parents and babies with lactation, but we don't always stop and think, is this actually working? Am I moving the needle with my data? Is there somewhere else my efforts and priorities should be really concentrated to make a difference and reduce disparities? Anyways, so Emily will discuss each of the strategies on the recommendation 4, and also she's going to let us know what she's been working on to help anyone start looking at the breastfeeding data. Then we're going to hear from Tammy and Ted from Partnership for a Healthy Lincoln. They'll talk about their long-standing work to build a community breastfeeding dashboard and how they have been engaging local partners to also share this data. Then we will hear from the County of San Diego Health and Human Services Agency, who is also in their 5th year of being a CDC REACH recipient. Naomi, unfortunately, was unable to be here today, but I wanted to give her a shout out because she has been a tireless advocate for breastfeeding data standards for years. And we hope that after this webinar, you will join her and us in these efforts. So Shayna, Naomi's colleague and counterpart, will be discussing the electronic health records and its capabilities. Then we'll hear from Brenda, that is currently our Blueprint grantee from the Kansas Breastfeeding Coalition. And she has been in a quest to identify who, what, why their community partners are collecting breastfeeding data in their region. And Carmen will close our webinar series in celebration of being our grantee extraordinaire for the past 2 years and the only grantee who have implemented all Blueprint recommendations. So these presenters have contributed so much to the infant feeding field. You can see all their bios and resources that is being shared through this webinar resource guide. It also will be available in our continuity of care website. So this is a very summary of the last 2 years of the Blueprint. The blueprint was launched in 2021, but the work really started 2018. 2021 to 2022, we had a lot of people download the blueprint, and then we had 10 communities grantees implementing the blueprint. We also built our continuity of care library. And then the last year, we had 7 additional communities implementing the blueprint. We're almost at 2,000 downloads of the blueprint. We are wrapping up this 8-part webinar series on the blueprint. And we also being the blueprint has been forming our blueprint sustainability series for technical assistance to reach recipients. If you haven't downloaded the blueprint or haven't visited the community, the library, you can go to this link there that is also being shared in the resource guide. Oops. All right, so like I said, this is the 8th webinar of our 8-part series. We had webinars in every recommendation. You can go watch the recording, and there's still continuing education available. So the link is here, but it's also in the webinar resource guide. But today the focus is really on recommendation 4, which states to develop a shared community breastfeeding database system to track infant feeding consistently for community health collective impact efforts. On the screen, you see what recommendation 4 looks like. It's like a standalone recommendation, and you can download from our website. So the blueprint, each recommendation includes a set of strategies. This one has 5 strategies, a set of resources to implement the recommendation, and some examples from the field. So recommendation 4 strategies include 4.1, assess availability and accessibility of existing community level breastfeeding data systems among local healthcare systems, WIC, local and state departments to leverage a shared system. 4.2 talks about standardizing and sharing indicators among community stakeholders to facilitate shared community relevant breastfeeding surveillance, data collection, and reporting systems. So indicators, and you're going to hear Emily talk more about this, but includes breastfeeding initiation and exclusivity, birthing outcome data, local lactation support resources. Some people use the GIS information, family demographics, and so many other types of data. 4.3 talks about developing a data sharing agreement, outlining what data users should report and can access, and other data users' rights and responsibilities. 4.4 talks about designating a backbone organization to support others in using health data. And 4.5 talks about healthcare organizations assessing the electronic health records or medical records capabilities and updating templates to query and collect appropriate breastfeeding data accurately and inclusively. So you're going to see that our speakers today will address one or more of these strategies. But before I turn it over to Emily, I wanted you to bear with me here in my dad jokes. So date your data, right? The main goal for today's webinar is that you be inspired to start to get to know your data, right? It's like getting to know someone, like when you're on a date. Or if you already know your data, we want you to spend even more quality time understanding it better, seeing what else needs to be done. So last year, I put together an informal breastfeeding data powwow, just to understand how some folks were using their data. And then I had a pleasure to meet the Minnesota Department of Health epidemiologist, Marcia. Like, she's the best. She makes talking about data completely non-intimidating. And then look at this. This is a dream data they put together and consistently on a regular basis. It's part of their job. This is the best sample of disaggregated breastfeeding data I've seen. And this is because the Department of Health has really made equity, or including equitable access to data, their priority for over a decade. And that includes disaggregating data as much as possible and making it easily available for anyone who requests. I was very impressed of how much they were able to disaggregate this weak data by cultural identity. Look at this, or ethnicity. You see here on this table that Black infants at the breastfeeding rates at different milestones, but you can see here that they didn't make Black families a monolithic group as we usually see on data reporting for Blacks, right? They really took the time to create intentional data collection spots where families can select their own cultural identity. And then they broke down the data. African Americans and families from the African immigrant diaspora. As you can see, they include Somalians, Liberians, Ethiopians, Kenyans, Sudanese. So very, very impressive, right? And then you see here another graphic of breastfeeding duration data trends. So this reflects WIC and non-WIC participants, but this is from the vital records, actually. So they notice this persistent trend here on the bottom, that is the Hmong breastfeeding rates were consistently the lowest from all cultural groups. So they engaged the Hmong communities and they met these amazing Hmong families and professionals and started the Hmong Breastfeeding Coalition. And the Hmong Breastfeeding Coalition were actually our grantee 2 years ago. And with this quantitative data, they started doing a community lactation assessment to understand their qualitative data. So they're thriving as a coalition now. And I hope this little date story illustrates how data is essential to take any meaningful steps towards addressing any health disparities. And you can see their data, quantitative and qualitative data in their assessment, in their environment scan that is available in the Continuity of Care library. So Emily's gonna talk more about each of what this entitles, and I will turn it over to her. Emily is my longtime partner in crime, or actually, should I say my partner in continuity of care? That joke is not as funny, right? Well, sorry, here's Emily, and we're gonna launch a poll.
Thank you so much, Harumi. So Harumi started using some really big data words, and we're going to talk through a lot of those today so that hopefully I can live up to, as she said, making data a little less scary for you. So the first question to ask is, if you are a part of a program within your community, it could be WIC, Nurse Family Partnership, a variety of community-based organizations, even a large FQHC or a hospital. If you implement a new project or program, true or false, you do not need community level data, in other words, outside your program, to know if your new program or resource is working for you. Let me know what you think, true or false. So it looks like the majority of you said false, 94%, and only 6% said true. So rock on, we're gonna learn a little bit about why that is on this next slide. So if you thought it was true, let's look at an actual program implementation in a community. Many of you are thinking that you know what the issue is. We lack support, we lack education. But if you do not know what your community rates are, what happens when you start a program and want to determine if it was helpful? Here is a great example of a program that began, and those who participated, they felt were well supported and they felt were doing better than most. However, the only comparison they had was initiation within the program and that of the general initiation rate. Therefore, they felt the program was successful, but they really couldn't compare it to the community, so they really couldn't know for sure. And therefore, their conclusion was, well, more evaluation was needed. What does that mean? We need more data. So when we take on new interventions, policy-based or programmatically, if we do not know what the community picture is, we cannot truly know what has made a difference and what has not. Sure, we can compare within our own programs, but isn't the goal to know what works past more than one organization or one program? We cannot change community health when we think about it as a program to program. We must think about it as a whole and what is needed to help support the multiple pieces that make it up. This is the core root of collective impact, in that breastfeeding cannot be improved exclusively by one individual or one organization. And so we're trying to tackle an issue that is greater than that one person or greater than that one organization can solve. Once you have data, you can begin to paint a picture of what some of the issues are. Often data will illuminate some gaps, differences between groups or individuals, or even facilities and zip codes. This is what we call disparities. So how then does data help us understand disparities in breastfeeding? Well, it allows us to see the differences between a variety of groups and measure the differences, to ask the question of why is it different and determine strategies to improve with a wide variety of stakeholders. If we do not understand what disparities exist, it is difficult to know what policies or programs may even be needed to best improve and support a family's desire to breastfeed. Like this program highlighted, you have to know what the norm is to know if items that have been tried make a difference to the entire picture or only a piece of it. This is equity, not equality. Data helps bring these to light. So let's learn where you can start to begin and get some of this data that exists in your community. Many of you may be familiar with the Centers for Disease Control databases. Right here, what you're seeing on these slides are a wide variety of what is available through the CDC data available website, both national, state, and more recently, community level data. You should always start with knowing what data already exists for your community and where it comes from. The CDC has an extensive database that covers national, state, and some county rates. Now, this comes from multiple sources. The county data was the latest addition, and it actually comes from the National Vital Statistics System, which looks at over 3,000 counties or county equivalents in 48 states. So you'll notice that there's a couple states on this map that are shaded a little bit differently. It's not that they don't have data, such as in California, it's that they have their own data mechanism systems that are in place. Michigan is another one that is not represented. However, others are. And unless the total number of infants or number of infants initiating breastfeeding was less than 10, pretty small number, then those won't be displayed. So in other words, the majority of your communities can go to this great website and find information, not just about comparisons for the national and the state, but even county level data. Now, data generally comes from these two sources, either the National Vital Statistics System or possibly birth certificate data. California, for instance, pulls a lot of data from their birth certificates. This includes infants born, and they measure initiation. Hospitals also then look at exclusivity. Now, the NIS data also measures breastfeeding initiation, duration, and exclusivity, but this is gathered via cell phone among a nationally representative sample of people with children ages 19 to 35 months. This survey only looks at children born across the 3-year time frame, and they report on this based on birth year. So this is a good starting point when you're trying to figure out what you should be looking at. Where else, however, should you be looking? How about hospitals, WIC, early Head Start, nurse-family partnership, community health assessments? Local health departments do these, as most do hospitals. Social media, focus groups, and support groups. These last ones, you're probably thinking, how do I get data from there? And we're going to talk about that. But tell me in the chat box, where else do you get data on your community level? Think about it, because you know your community best. So let's help teach as I speak on. So tell us in the chat box as I move into this next slide, where else does data come from past what you saw represented here? Now, you heard Harumi mention quantitative and qualitative data. What is that? Well, to gather information from families, we have to ask ourselves which type of data matter to obtain breastfeeding community plans or even projects. It's both qualitative and quantitative data. Because while having quantitative, think of numbers, are helpful to understand the disparities, your qualitative data can help understand the community at its deepest level and often can be gathered and represented in a quantitative form. So when I talk about going to social media platforms and breastfeeding support groups to understand your community, that is qualitative data. We, however, can turn that in to quantitative numbers to help understand some disparities. Or we can do what we call a thematic analysis and start pulling out some of those root causes when we hear from our families about what some of those issues are. So the main takeaway that I want you to remember is quantitative is numbers, qualitative you can think of as stories, and it helps you understand the root cause. And you cannot understand your community unless you understand both of these data sets. Now, moving forward into what this looks like in the blueprint, there are two places that we talk about data. And if you did not watch the webinar from recommendation number 1, make sure you go back and look at that, because many of these data sources we're mentioning, community health assessments, things like that, those are mentioned heavily. Families live, work, and play in a variety of places. We need data from each of these to tell the whole story for our community health. This is why recommendation number 4 asks us to develop a shared community breastfeeding database system to track infant feeding consistently for community health collective impact efforts. Well, how do you know who breastfeeds in your community? Who wants to breastfeed and meet their goals, or who does not meet their goals? How do you see the differences between a variety of data markers, age, marital status, race, ethnicity? If you cannot identify these basic items, you are missing a large part of your puzzle. Data is central to telling your story and knowing where the work needs to be done. It's also greater, again, than any one person or organization can compile, and therefore, this is a community effort. After change rapidly across the first weeks, when breastfeeding first initiates, we know that then there's different time markers that we need to be careful and mindful of when we are tracking breastfeeding data. So again, this is why we cannot centralize our data on, say, just breastfeeding rates from the hospital or from WIC. And we're going to talk a little bit about more why that's important when we talk about the cautionary tales from looking at your community data. You should be looking at a wide variety of places to help you see the whole picture, to understand what and who is in the community and what data matters. Because see, if the majority of your birthing population is eligible for WIC, those rates may be utilized to understand what feeding behaviors are for the community. However, if a large percentage are not eligible or are not enrolled, that data would not be great enough to understand the community behaviors. It's only a sample. In other words, you got a slice of the pie. I need you to find the whole pie. Data may also come from informal sources, community health surveys. Some of these are often conducted by community-based organizations, maybe even researchers, early childhood education centers. So it's a variety of places that this data comes from. So again, think of it like a whole pie, and each of those is a slice. Together they can make a whole, but also when assembled, they start to show you where some of the bites have already been taken out. That's what we call disparities. Many agencies might be collecting this breastfeeding data in any given community. However, the type of data collected and the indicators may not align with each other. In fact, there is a lack of nationally standardized breastfeeding-related definitions that have corresponding measures and mandated collection points. Now, if those of you who work especially in FQHCs might be familiar with the term HEDIS, Healthcare Effectiveness Data Information Set, we don't have this measure set for breastfeeding that helps to identify opportunities for improvement, monitor quality improvement, and provide a set of measurement standards. So health centers, provider offices, lactation support practices, and other outpatient settings might also be collecting some type of data, and they may have it electronically. And guess what? Those systems don't talk. And no matter how much effort we've put into it across the decades, healthcare providers have sought systems to enable them to talk and flow, sharing aimlessly, but we're not there yet. So this connectivity is a real issue along with the standardization. So we're going to move into some of these recommendations a little bit. This first one, 4.2, to standardize. Again, as mentioned, we don't have nationally recognized markers. This is mixed. Although this study that is presented here is looking at why we need infant feeding data at international levels, what's important to recognize is that it translates to your community, because we need to know, again, what's happening. So they recognize that there's a wide variety and types of methods of data that is happening. And to overcome this, systems have to be set up. You first have to define what you're gathering, set definitions for each marker, and timing is often coming at different points in the breastfeeding trajectory with a family. So the authors concisely and precisely state, effective data use is affected by the level of detail collected. Therefore, each community must ensure their indicators are defined well and universally so the whole picture is clear. Ensure that the one clinic and the next are comparing green apples to green apples, not green apples to red apples. They may both look great and they may both taste great, but guess what? They're not the same thing. So moving forward, when we look at 4.3, this is asking us then to develop data sharing agreements. Some of you may be more familiar with the term MOU or Memorandum of Understanding. This is just formalizing saying, hey, we're going to do this for data. And this goes back pretty deeply, even into what we called Public Health 3.0 at a national level, which was part of the Healthy People goals. And we asked for prioritization of data sharing at federal, state, and local levels. Now, the network of public health law helps us with a checklist to even begin these initial steps of data sharing agreements. That link will be in the chat box for you. And here you are seeing snapshots from it. And the goal, of course, is to provide factual information. And it does that by asking certain questions around proposed data collection, access, and sharing. So this checklist can serve as a wonderful activity for your organization or work group, but also collective impact work groups to begin asking those hard questions and getting those hard answers. Now, 4.3 asks us then furthermore to look at this from, say, the state perspective and what else can be done. So it goes pretty deeply. And the California Healthcare Foundation helped advocate for legislation in California that actually is moving forward in implementation with certain models. And you see an example of the model on this that I put up there just as a screenshot. And the link, of course, will be in the chat box. But what's important here, and very much segments into the breastfeeding world, is that they are collecting clinical and non-clinical data, including behavioral health, social services, and everything in between. So this is really crucial. Now, you've heard a lot about collective impact. This next strategy, 4.4, talks about the backbone organization. What is that? Well, being a backbone organization really means asking yourself, how do you get people to work with you who don't work for you? So here we see a field example of Public Health Solutions working with a multitude of partners to train and collect data. A really good example, but you'll see that they had some lessons learned and that it was very difficult. So on some of my last slides, as we start to transition over, this is another handout and resource that can really help with some key points for your collective impact work to understand what a backbone is. And then I do want to highlight really quickly some last examples from the field. And this, again, like Public Health Solutions found in Erie County in New York, they needed data. They had partners, but they needed to work together. And so what they did was they figured out what data was available. And on this next slide, you'll see how it then informed a fabulous logic model, both for short-term and long-term. And you'll notice the data then tracked these outcomes. So I know that was a lot in a quick few minutes, but just to give an overview, the toolkit is going to hopefully help communities understand what collective impact is, an overview of common data accessibility points. It's also going to give activities and further explore recommendation number 4, some checklists, and of course, field examples. So I know that was a lot, and without further ado, we're going to turn you over now to some fabulous grantees who have done this data work. So I'm going to first turn it over to our Reach and Blueprint initiatives from Lincoln, Nebraska with Tammy Frank and Ted Frazier from Lincoln Community Breastfeeding Initiative.
Hi, thanks, Emily. Tammy Frank, I'm with Partnership for a Healthy Lincoln. I am the program manager or one of the program managers for our REACH grant, as well as kind of the program coordinator for our Lincoln Community Breastfeeding Initiative, which we'll talk about in a bit. Just a little snapshot on Lincoln. We're there in the southeast kind of corner of Nebraska. There's about 320,000 people in Lancaster County. Lincoln is a majority population of that county. We have just over 3,700 births per year. And we're a refugee resettlement community. In fact, the largest per capita in the United States. There's 125 languages spoken in our public school system. Our local coalition started in 2012 with both of our birthing hospitals, some physician clinics, Milkworks, that's a standalone community breastfeeding center, because people found that moms were hearing things, families were hearing different information at different times from different places. And they said, we really just want moms to not be confused about anything. Let's provide some accurate, consistent information across the community. And that's really where the two birthing hospitals came together and developed a set of shared standards that they use so that a mom delivering in Lincoln, doesn't matter where they're at, will receive the same care. Those standards are based on the 10 steps, baby-friendly 10 steps. That's also when we started doing our data tracking within the hospitals. Beyond that, then we kind of expanded our coalition to involve more of that continuity of care, to invite and really looked at the community and saying, are we reaching all moms in our community? In 2015, we started a program called our Community Breastfeeding Educator Program, where we found women in the community that wanted to be advocates, trained them in breastfeeding, and that picture in the bottom right is a few of them from that program. So as Emily mentioned, there are a number of data sources, and we do use a lot of different ones to inform different things. There's benefits, so there's pros and cons to both. We like our local data that we're able to access mostly on the program side, just from the timeliness of it. So we can start to identify trends pretty quickly. We take most of our data, we take a look at as a coalition quarterly. And so we're able to identify potential trends, talk about why those might be happening, and kind of adjust our program to either highlight the good things or take a look at why things might not be working out as well. The benefit, obviously, of those larger data sets is that they have some things that we don't have yet locally, like the population level data that breaks down by race, ethnicity. So we can still track over time what those trends are. But a lot of times, I think someone has already mentioned, that can be a couple of years old by the time you're looking at that. And so it makes it hard to quickly pivot with your program to make adjustments there. I'm not going to stay on these slides long, but I know that they're available afterwards. So I just wanted to put out some of those shared metrics and definitions as Emily mentioned. So the birthing hospitals, when they came together with those shared standards, they also set definitions around skin to skin, breastfeeding initiation, next slide, exclusivity. We were also tracking documentation of education when non-medical supplementation was requested. And then we did a bundle approach where we were saying, does this particular birthing person, are they receiving that uninterrupted skin to skin, exclusive breastfeeding in the hospital, and documentation of that education. Then I'm just going to give a couple examples of how we've used local data to inform our programs. So this is a presentation that was given by some students from the College of Nursing. Next slide. We started to look at skin to skin rates. So through that hospital tracking, we saw that skin to skin was kind of low in 2015 and wondered why that was the case. So the College of Nursing students did surveys with all of the nurses at both the birthing hospitals to identify possible challenges and barriers to that, came back, presented it to our group, and kind of found that there was a lot of challenges or hesitation with physicians and staff when it came to C-section births. So we have some physician champions. We're fortunate enough to have physician champions that, kind of develop some education around that, the benefits of skin to skin, how it can work in the OR. And then the hospital, they went and presented, and the hospitals had to figure out, maybe we do a different layout in the room. Maybe the, anesthesiology had to be in on that. And there was a lot of discussions there, but they were very receptive, made changes. And then we partnered with the two birthing hospitals to, kind of share that success with the National Hospital Association newsletter. And that has maintained. Our skin to skin rate in the last year is still around 93%. Initiation has always been high, around above 90%, which is wonderful. Exclusivity is an area that we still need to work on, and we're around 70% there. But it wasn't always that way. We used to have around 90% exclusive breastfeeding in the hospital. And so in 2017, when we started to see this decline, again, with the local hospital data, we brought the group together and said, what's happening in the hospitals? Why is our exclusivity dropping? And just feedback from lactation consultants about what they were hearing from families and their physicians was really kind of mimicked the message around fed is best. So moms, we know, over 90% of moms are wanting to breastfeed. They're initiating breastfeeding, but kind of at that first sign of trouble, there's trepidation there about, I've got to make sure my baby's fed. And so we see a lot of that supplementation happening. So still work to be done. On the WIC data side, I've heard WIC mentioned a couple of different times. This is a wonderful data set for us and probably the longest data we've had, along with the hospital data. So we started to see there in March of 2020, of course, as you've seen, I'm sure, across the country, the declines, particularly in exclusive breastfeeding at 1 week. We saw that throughout the pandemic. People were being discharged much quicker. But then something happened in March of 2022, where we started to see this increase. And uniquely, all the data points at 1 week, 3 months, and 6 months all started going up at the same time, which isn't necessarily always how you see that. It's tend to be delayed. So we talked to our WIC folks and said, what's happening there? And they said, there's kind of two things that happened around that time. We did this training with all of our staff around breastfeeding. It was a 40-hour training that WIC provided. Happened to be around the same time as the formula shortage. So as families were being very receptive to messages about breastfeeding because they were worried about the formula shortage, WIC staff had just been trained and felt confident to talk to families about breastfeeding and about maintaining breastfeeding. So, and we're continuing to see that go up. Again, this is any breastfeeding over that same time. You see around March of 2022 is when we start to see increases. A couple other things of how other small data sets, you can go to the next slide, how we've used kind of smaller data to inform education efforts. So this is one where we did focus groups at our cultural centers, talked to families about what information they needed about breastfeeding, what information they felt their families or the community needed around breastfeeding. And two main themes popped up. One overwhelmingly was just families not knowing their rights. And so we did a photo shoot with some of our local moms and put it on the side of a bus and sent that around and got some great coverage around and conversation around breastfeeding and mom's rights. Also, the one around support was important. And so we put those on the inside placards as well. The last piece here that I'm going to share is just some kind of local level data. So I know we talk about sample sizes and how much you can share and all those things, but there are interventions happening within our community, particularly within our cultural centers, that are really effective and having wonderful impacts on breastfeeding rates. And while those interventions might not be as large, we want to be sure to recognize and highlight those programs that are doing well. So I will hand it over to Ted to talk a bit more about some of the other data.
Thank you, Tammy. As Tammy mentioned, we use a lot of different sources of data, one of which, of course, is PRAM. So most of the folks on the call will recognize, of course, the Pregnancy Risk Assessment Monitoring System. So Nebraska, we have over 20 years worth of data. And we'll just kind of flip through these next few slides. We won't take too much time, but just show the different measures that are available in those data sets. So you can see there, receiving services, hospital support, initiation, still breastfeeding at the various time frames, reasons why it stopped, and first solid food. And again, these will be in the slide set. The thing we want to take just a couple minutes here and visit about is our use of Tableau. With the Partnership for Healthy Lincoln, the Partnership for Healthy Nebraska, we really strive to create interactive publicly available data visualization. So we use Tableau, which is a software, an app to do that. At any given time, we'll have usually about 36 different interactive visualizations on our website on a variety of topics. This has been relatively successful. For example, during COVID, we had over 100,000 views, and we're a relatively small state and small community, so it is pretty successful. So a couple examples here, adequate prenatal care. You can see at the bottom, we let users choose which year they want to look at. On the next slide, we'll see this one. These are by health departments, and you can see at the bottom there. You can select year as well as payment source, and the visualization will change. On the next slide, we'll see this has a choice of a number of different adequate prenatal care type measures. So again, we get a lot of use of these things. And I believe we have a couple more examples here. This one is WIC data, of course. And the next one. This one you can see on the lower left, choice of a number of different measures. And then on the right, a user can select any group of states. So if they want to have 1 state or 5 states or 10 different states, they can go out and create a graph, and then they can use this in their presentations, for example. And I think this one, again, a user can select any group of counties within the state. So for example, health departments may pick 4 counties, and then this automatically in the upper part there in the red calculates the rates for that group of counties that they select. And then finally, just a couple examples. Tableau is fairly robust. If you want to get a little bit more detailed, you could get into things like scatter plots. These are just examples, but you can see we'll have 3 or 4 different measures at a time. This is proficiency in education versus free and low-cost meals. And then a person or user can select a certain school district and see how their schools compare to the rest of the state. So just to kind of wrap this up, the good thing about Tableau is you do not need a huge IT staff or infrastructure to do this. This is pretty straightforward, pretty simple to do. So if anyone has questions about how to do this, certainly give myself or Tammy a call, and we'll visit with them about that. And then just in the terms of the big picture here on the final slide, the next slide, in terms of building a community dashboard, this is tricky. And one of the tricks, of course, is getting at least a common metric across programs. And that's something we're all working on. It's certainly a work in progress for us. So if anybody else has this all figured out, we're certainly happy to learn and hear from them. And with that, I believe the next speaker then is Shana from UC San Diego.
Thank you so much, Ted. Really appreciate that. And I just want to thank you all for this opportunity to talk about our work in exploring electronic health records to assess infant feeding practices in our community health clinics and outpatient settings. I think what I'm hearing from the previous presenters is a lot of what we explored in this project. And Naomi was unable to be here today, so I'm presenting on her behalf, but we're really excited to be continuing this conversation with you all. I wanted to set the stage for a little bit of background on this work. And this work was actually part of a lactation supportive environments project that aimed to increase access to settings that encourage chest breastfeeding initiation and duration. It was funded through First 5 San Diego. It's a project of the County of San Diego Health and Human Services Agency. And then my institution, UC San Diego Center for Community Health, implemented the program. And a really important component of this work was partnering with 6 San Diego County community health centers to create a more chest breastfeeding friendly venues for both patients and employees. And as part of our efforts, the project provided support, training, and technical assistance to 6 community health centers across 6 different systems in 10 key areas that were modeled after the 9 steps to breastfeeding friendly guide for community clinics and outpatient settings. And looking at the data that these clinics were collecting around infant feeding through electronic health records was one of the key areas that I'm going to focus on today. Go to the next slide. So when we started working with each of the 6 community health centers, we conducted an initial assessment to understand where each clinic was in terms of the 10 focus areas. And we soon realized there were challenges with tracking infant feeding and chest breastfeeding rates. And so we decided to shift and focus on an exploratory project for this focus area. We conducted a series of 18 in-depth interviews with subject matter experts and key stakeholders. And our sample represented a diverse group affiliated with relevant local and national agencies and organizations, as well as representatives from 4 of the 6 clinics that we're working with. And our expert informants, subject matter experts, and key stakeholders were affiliated with the American Academy of Pediatrics, both our local chapter and nationally, Academy of Breastfeeding Medicine, Association of State and Territorial Public Health Nutrition Directors, the California Department of Public Health, California WIC, Centers for Disease Control and Prevention, the International Lactation Consultant Association, and our local San Diego County Breastfeeding Coalition, and then including our community health centers. And some of the folks we interviewed for this were affiliated with or represented more than one organization. And from these interviews, a report was developed to outline the findings, including some short and long range recommendations. So as far as key findings go, our subject matter experts agreed in their assessment of infant feeding measurements in electronic health records and really described the current state with words like minimal, limited, spotty, and even non-existent. Several noted that hospitals are farther ahead in electronic health measurements around infant feeding due to the Baby-Friendly Hospital Initiative requirements of tracking initiation rates within the hospital setting. And when we spoke with our 4 community health care center representatives, all were currently using electronic health records. 3 of the 4 were using different vendors, and not all of them had started incorporating lactation services into their electronic health records. So the types of data being collected around infant feeding in electronic health records varied across the clinics, including basic measures such as collected prenatally like intent, and data collected postpartum such as feeding choice and exclusivity. 2 of the clinics we were working with actually revealed they capture quite a bit of chest breastfeeding data via electronic health records because they're part of the Comprehensive Perinatal Services Program, or CPSP. And this is a program that provides a wide range of services to pregnant women receiving Medi-Cal benefits from conception through 60 days postpartum. And the CPSP program mandates documentation and reporting requirements. They're quite extensive, but the sites have some autonomy in selection of forms and how they record and track the services provided. So 2 of our sites had embedded these CPSP forms into their electronic health records as a way to track some of this data. As you heard from some of the speakers before me, there's a lot of barriers and challenges to this as well. So we can move on to the next slide. And, Emily touched on a lot of the same barriers and challenges that our key informants agreed on. There's a lack of common definitions to describe even the most basic breastfeeding behaviors and outcomes, and the lack of standard accepted core set of questions that really hinders a broader adoption of breastfeeding measurement in electronic health records. We don't know what folks are collecting if they're using the same definition for the metrics that they're collecting. There's also a lack of external requirements for this data reporting that was cited by our subject matter experts, and that was a significant barrier to greater inclusion of measures in electronic health records. Some of our interviewees noted that health plans are not currently required by any mandate or quality improvement to collect and report this data. And many of our experts commented various system constraints contributing to factors to the lack of electronic health records-based infant feeding measures. There's a wide variety of vendors for electronic health records and products. Some have built-in spaces to report infant feeding related questions and others don't. There also may be a cost associated with turning on or adding these modules. And some of our clinics we were working with actually have a homegrown electronic health record system. So at times they may have more autonomy to make changes, but working to request these updates really depends on an organization's information technology capacity. And one of our interviewees commented that working with her organization's internal IT took 2 years to achieve breastfeeding related changes to their electronic health record system. So it's not always fast and easy with a homegrown system. And in addition, when existing infant feeding questions are not available as a clickable field or have a designated area to report, clinicians may be documenting in open note fields, which really doesn't lend itself to a systematic data capture or generating reports to track these rates. And as mentioned earlier, systems also frequently lack the ability to communicate with one another. So that really makes data sharing and individual patient tracking and monitoring challenging, although California is on its way to a data sharing agreement. Then there's also concerns from the healthcare providers, including time and balancing interest and needs of primary care and public health. And amongst our clinical experts, they reported a steep learning curve for electronic health record use. And some even conceded that electronic charting can take more time rather than providing greater efficiency as it's marketed. Additional measures could equal additional time spent on chart completion. And in regard to balancing interest and needs, some reported that clinicians are unlikely to endorse these additional infant feeding measures integrated into electronic health records if there's not a clear, apparent connection between the measures and direct patient care, or if the end goal of expanded measurement is not clearly articulated and recognized. And we had one interviewee say, we want clinics to not just have the ability to collect the data in their systems, but see the value in it. So that means the clinics have to place a value on breastfeeding support and inputting and collecting the data. So while there are a lot of challenges, there's also a lot of opportunities. So many of our experts that we interviewed acknowledged opportunities, including a consensus around the need to institute a community accepted definition and an agreed upon standard of measure for infant feeding. However, there wasn't a consensus on the organization or agency that should take leadership role in defining these measures. Recommendations included, the AAP, Academy of Breastfeeding Medicine, California Department of Public Health, the CDC, Centers for Medicare and Medicaid Services, and the United States Breastfeeding Coalition as potential organizations or agencies that should take a leadership role in defining these measures. Experts also agreed that making a case for the value of the data for direct patient care and beyond is needed to gain buy-in from health professionals most responsible for patient charting. There's a need to engage champions in clinical and public health settings to provide messaging about how this data can be used to improve patient care and community and population health. Quality improvement efforts appear to be underutilized in infant feeding medicine and care, which could create interconnections between direct patient care and larger public health issues. I saw someone put in the chat, every time I go to the doctor, I'm asked, about smoking. So why can't we equate infant feeding measures to that? Many of our experts interviewed recommended an approach that would create a greater market for this data and make measurement imperative to citing the strong connections between infant feeding measurement and other pediatric and chronic health issues. While others advocated for the adoption of one or more measures as recognized quality measures around infant feeding. And there was the opportunity to model after the Baby Friendly Hospital Initiative to develop a certification or designation that would mandate and incentivize data collection and reporting in community health clinics and outpatient settings. So ideally, a designation could recognize and support the continuum of care that begins prenatally to birth through postpartum, encompassing both the birthing parent and the baby. And again, there wasn't a consensus around the entity that should develop and oversee a designation or recognition. So from this report, we developed some short and long range recommendations that align with the continuity of care strategies. And the short range recommendations really included capitalizing on the interest of our community health clinics that we worked with and further collaborating around infant feeding measurement and electronic health records, including opportunities to convene a work group of partners to explore opportunities for dialogue. We also wanted to challenge the community health clinics to conduct more comprehensive environmental scan of the data that's currently collected by their electronic health records and other means, and explore ways that this data can be used beyond our direct patient care and audit purposes, including quality improvement efforts. We'd also like to encourage our community clinics to leverage existing comprehensive perinatal services documentation and reporting requirements around education, support, and guidance to consider other ways that data might be used to influence infant feeding. And for outpatient settings early in their electronic health record journey, or community clinics that are adding lactation services to an existing system, really encouraging thoughtful thinking around measures, data collection mechanisms, and charting related to education and support, with the understanding that lactation is unique in its care and clinical encounters because it impacts two charts, both the parent and the baby. and to be aware of challenges with community clinics where they may offer prenatal but not pediatric care, and or vice versa. Long-range recommendations really include promoting dialogue at the local, state, and national level to encourage development and adoption of an agreed upon set of definitions and corresponding measures. And I think we've heard that a couple of times today. And we're excited to continue this conversation and explore this opportunity with you all. Also, creating and adopting one or more quality measures and subsequent financial incentives for reporting. From a systems perspective, financial incentives are a powerful motivator. Looking at advancing the discussion around certification and designation for outpatient care settings, this would not only provide incentives that would recognize and legitimize the continuum of care. Advocating for interoperability between electronic health record systems. We know that data silos will remain until the systems can communicate with each other. And really focusing on engaging key organizations such as you all here today, the USDA, WIC, the CDC, and others to work together to build and test electronic health record fields for lactation as a model, then test and refine the model to work for multiple systems and ensure that the same data is being collected across different systems so it can be reported and compared. And, as Emily mentioned, California is moving towards a data sharing agreement, but the above recommendations to refine what does infant feeding data look like, how is it measured, are really important at this. So I want to thank you for this time, and now I'm going to turn it over to Brenda.
Thank you so much, Shana. That was perfect timing and a great segue to what we're doing in Kansas. I feel like we're really building on the work that you just described. So thank you for that. I actually feel like what we're doing is a bit of a jigsaw puzzle, and we're all putting pieces into place with Nebraska and what Shana just shared. So here are the pieces of the puzzle from Kansas. We started with this NACCHO project. Actually, everything I'm going to share with you in the first half of my talk is work done by Carmen Valverde and her coalition, Lactancia Latina of Southwest Kansas. So you can get oriented to, we're talking about the state of Kansas. Carmen's coalition works in the 19 counties of Southwest Kansas. And I did make a note that we do have 4 meat processing plants in that area. And the reason why that's important is because it does impact the populations that we're talking about in that community. If you're thinking of rural Kansas, you might not know that that corner of our state is nearly 45% from Hispanic or Latinx communities. So that is something that you might not know if you didn't know about this map. So next slide, I'm going to tell you about our survey that Carmen did in those 19 counties, asking the very questions that Shana mentioned. What are you collecting? What breastfeeding data are you collecting through electronic health records or electronic medical records? So we surveyed these counties, and you can see that we had a response from 12 counties, mostly from our friends in public health. Our local health departments really got on board with their responses. We also heard from, as you can see, hospitals, other nonprofits, FQHCs, and a WIC agency that is outside of a health department. So there's some great examples of a diverse group. And you can see that the majority of them are in fact collecting breastfeeding data. And this first question, by the way, just was any breastfeeding data, not necessarily in an electronic system. And half of them are collecting in an electronic system. And by the way, everything I'm sharing with you is going to be in a full report and analysis that will be available at the end of July, along with our final report to NACCHO. So this is a bit of a sneak peek, if you will. Next slide. The group also reported that, yes, the majority were collecting information on breastfeeding exclusivity, and we did give them the definition of breastfeeding exclusivity as defined by the Academy of Breastfeeding Medicine. So they understood what we meant by the term exclusive. They also mentioned that the majority of them were collecting breastfeeding data at more than one point in time. And interestingly, of those 6, the majority were collecting them within the first 2 weeks postpartum. So again, probably tied to that well baby check that they are seeing. And they were able to link parent and infant records together, which we know has been a barrier in the past, but apparently has solutions have been found on how to do this. So that was actually kind of surprising to me, because I kept hearing from systems that this was challenging, but apparently the majority have been able to figure out how to link those two records. And then near the end of the survey, we were asked about, do they routinely review their breastfeeding data internally? And again, the majority said that yes, they did. And this part I think is the most exciting. Were they able to generate reports? Yes. Were they able to export those? Half of them thought so. But look at what's on the bottom of the slide. The last question asked, would you be willing to share your breastfeeding data de-identified with others in the community? And no one said no. So I think, to me, this is a huge welcome mat thrown out to Carmen and her coalition to say, you know what, we can start connecting these entities and maybe start forming together some sort of a data sharing agreement, because nobody said no. So I think that this is probably the highlight from there. We also gave to these same 19 counties a self-assessment tool. We really thought, you know what, if we're asking you about your practices, it might be good to give you an idea of what best practices are. And Shana and Naomi, we did build on your best practices that you had built, and we just built on that some additional questions. So this is an old-fashioned paper and pencil PDF document that they could use to kind of think through what is it that they do. And you can see these questions here. These next few slides are actually screenshots of the assessment tool. We thought it was important to document the practices around breastfeeding, more than just charting. The next slide. And also education opportunities beyond just the prenatal, because sometimes we're only charting about those first 2 weeks. We wanted them to think beyond the first 2 weeks. So you can see weaning education is on there. And actually that's something that's not normally part of breastfeeding education. So we really wanted them to think holistically. We also wanted them to think about referrals, because Carmen and her coalition learned in the needs assessment that they did in recommendation number 1, that so many families didn't know about the breastfeeding resources in their communities. And in rural communities, they have to travel great distances. And so it's difficult to get the word out. But we know that these systems, like health departments, play a big role in referrals. So we wanted them to think through, are you referring to outpatient clinics, other community resources, and to really give them a robust list of referrals. We also wanted to know about their breastfeeding assessment tools. What are they using? And as you all probably know, when you ask a question, simply asking the question is education in and of itself. So by asking, do you have a breastfeeding assessment tool? Some people might be thinking, what? A what? And we give them some ideas about what that is. So we're hoping that, again, this tool and this assessment tool is an education piece as well. And then we did need to carve out the hospital setting, because we did recognize that they have a very different set of questions that they might be needing to collect around breastfeeding. So we have a subsection just for the hospital setting. So it's both, so that this tool could be used in community and hospital settings. Okay. So now I want to segue to something that's a bit bigger than the 19 counties of the Lactancia Latina Coalition. This is a bigger project that we thought might be helpful to this webinar when we're talking about data. And in Kansas, we developed this, I call it the spreadsheet for lack of a better name. And Ted and Tammy, I'm going to be getting a hold of you so you can help us to visualize this in Tableau, because it is a spreadsheet. But it has all 105 counties in our state. And we began to collect breastfeeding data and indicators that we thought might be helpful to, honestly, our local coalitions, because they were asking us questions like, do you know how many IBCLCs we have in our county. Do you know how many childcare providers have got that designation you all are giving out? And so we started collecting the data, and that was the birth of this Breastfeeding Coalition. I'm sorry, spreadsheet. Harimi, could you go back just one more slide? Sorry, thank you. I just wanted to point out what I think is really important is that it's updated. We update it every January, once a year, with the publicly available data. So you can see I circled down there the data source. It was really important to us when we developed this that every single column had a publicly available data source, or we were able to tell you where we got the information from. So you could click on those. So the first column on the left, population data, comes directly from the annual summary of vital statistics, population and the number of births. Then we look at peer support. WIC provides us where their peer counselors are operating. We have La Leche League in our state, and we also have other breastfeeding support groups, and we monitor those as well. Again, everything is by county. Next slide. So we also have workforce development. This may be unique to Kansas, but we do give out education grants, and we have a Breastfeeding 101 and 201 series. We just added these columns to the spreadsheet last year because we recognize that we need to start keeping track of where these individuals are in our state because they're part of the workforce development pipeline that we're building. So the next column in green is clinical support. This is easier to get. We looked at IBCLCs. You may not know this, but you can actually send in an inquiry to the International Board of Lactation Consultant Examiners and request the number of IBCLCs by zip code in your state. They don't provide names, it's just numbers and zip codes, and then we translate that to counties. But we are able then to keep a finger on the pulse of where are the IBCLCs in our state. And similar to the CDC breastfeeding report card, we then do the math and come out with the number per 1,000 births. We do have a new column that we're calling mid-level lactation support providers. These are people that have completed a certification course, such as a certified breastfeeding specialist, certified lactation counselor. The list is growing. I think at last count, there were over a dozen different certification programs. If they're over 45 hours and they end with a certification, we're tracking them, and we have a separate page for that. But anyway, on to the next slide. So the next section is our systems level support. We're monitoring all of the designations that are given out in our state: hospital, childcare providers, employers. We have a breastfeeding welcome here window cling. And the first person who started this, thank goodness, required a form to be filled out before you could get the cling mailed to you. So we have a list of over 1,100 businesses and public spaces that have ordered that window cling. So we know where those establishments are, and we're able to have them in our database now. And yeah, next slide is the outcome measure. This is the data that you're probably most familiar with and other presenters have talked about, is the actual breastfeeding rates. So we have a laser focus on, because what we have available by county is very difficult to come by. So we do have breastfeeding initiation rate, again, from our birth certificate data. And then we're very grateful to our state WIC office that provides us with county level data for exclusive breastfeeding through 6 months. And they have given us, they give us that every year in January. And again, it's because I feel we have a really good relationship with them as the State Breastfeeding Coalition. And we're able to measure change over time since 2008. And look at that, we've doubled the numbers. So we're excited about that. But this is just an example of what a spreadsheet could look like. We built a similar spreadsheet for Arkansas and Virginia. And I just want you all to know it's possible when you start looking at what your data sources are. And at this point, I am excited to turn it over to the real star, Carmen Valverde, who is with Lactancia Latina. I think this is a perfect closeout to the last webinar in this series. Carmen has implemented all 7 recommendations. So Carmen, take it away.
Thank you, Brenda, and great job on your presentation. I don't know, is everybody able to see me and hear me? I don't have my video. I can't see my videos. So
Yeah, we
in the
can
last,
hear you, Carmen.
okay, there we are. Okay. So in the last 2 years, Lactancia Latina en el sureste de Kansas, with the support of the Kansas Breastfeeding Coalition and funding from NACCHO, has conducted community and partner assessments. So there's our slide. And then we've brought awareness to the community about existing breastfeeding resources in southwestern Kansas. We created a billing cohort in order to make advancements in lactation billing codes. We supported 1 midwife and 3 home visitors in certifying as breastfeeding specialist. Currently, we are supporting 15 members of Southwest, or community members of Southwest Kansas, to complete a Spanish-only CBS training, a course, and an in-person skills day. And we are also recruiting childcare providers in Southwest Kansas to take an English or Spanish How to Support Breastfeeding Mothers and Families course. And last but not least, we reached out to the community to engage stakeholders with the Lactancia Latina mission and resources. And I would like to thank everybody involved in these projects. Muchas gracias. Thank you very much. None of this would be possible without all of the support, just all of the amazing resources that are available from all the organizations that have already done so much work. So thank you so much. And there's our contact info for Brenda and I, if anybody should need it.
Thank you, Carmen, for sharing like a glimpse of the past 2 years that you've been with us. Thank you all the speakers for amazing talks. I think everybody did a great job, and we're gonna start the Q&A session very shortly here, but I really wanted to just take a minute to thank everyone who participated in 1 or more of our 8 webinars during this past 2 years. We launched this series with the launch of the blueprint on August 24th, 2021. We had like 1,200 registrants for that session, and it was amazing. Then every quarter we hosted a webinar focusing on each of the recommendations. Totally, we had over 20 amazing speakers like this ones from today, sharing their expertise and their successful implementations. And we had over 3,000 live attendees for the session, for the whole series. I also wanted to remind everyone that if you missed one of the webinars, you can still go back, watch the webinar, and still get continuing education credits for most of them. Anyways, just big thanks. Here's a lady dressed up so colorful that seems like she was dressed for this exact moment, right? Of celebration, the blueprint. So you have not noticed this, but each recommendation is a different color. Today we have our green color, and you see that the blueprint follows this pattern. So if you have watched all the webinars in this series, even the recording or the live, please email us. We would like to hear from you. And we also would like to honor you by giving you a special certificate, Blueprint Continuity of Care series. And also we would like to mail you a hard copy of the blueprint that looks really nice if you're interested. So if you do, please email us. And now, the continuing education information here for SERPs and CPUs, which are the continuing education for lactation support providers and for dietitian and nutritionists. If you want this one, then you're going to go to this link, and the links are being shared in the chat box or in the webinar resource guide. So again, for this one, it's a short evaluation and post-test for SERPs and CPUs. Now, if you want other continuing educations that CDC provides, that is the CME, CNEs, CACH, CPUs, CUs, that is for medical doctors, nurses, health professional or health educators, or just regular public health credits, then you have to go to CDC. This is beyond us. It's a long evaluation survey, not that long, but you're going to go to this link that is also in the webinar resource guide being shared in the chat box. Then you got to use this access code. Everything will be shared via email and also in the resource list. We're going to follow up with the recording link and those links too. We have a lot of questions, confusion questions about which link for which credit. So I hope this helps clarify a little bit. Now we will get, also I would like to announce that we are going to start our cohort 3 request for applications to implement 3 or more blueprint recommendations. So if you are interested, please stay engaged with us. You can subscribe to our newsletter. That's where we're gonna first inform everyone about the request for applications coming up this fall. We anticipate this being launched around end of August. So please be engaged with us. It's also going to be in the continuity of care website, so you can keep checking on that too. These instructions are also in the webinar resource guide. All right, so we are going to start our Q&A session. But before we start our Q&A, I really would like to hear one word or one sentence from each of you, and you can put in the chat box that is open again. I want to know, what did you learn? Tell me one thing that you learned about data, or tell me one action step that you can take towards understanding your local breastfeeding data more. So you can type in the chat box. And I will, thank you. Standardize and share, helpful, shared database, the logic model. Thank you so much. Learning many ideas for displaying breastfeeding data for our state. That's wonderful. I am going to stop sharing so we can all see the beautiful speakers, possibilities. Great, it's good to see that you're inspired to take some data action. All right, I'm gonna welcome all the speakers to turn your cameras on so we can all see your beautiful faces now. All right, so first question here that I have is for, where is it? For Partnership for a Healthy Lincoln. I think I love seeing Kansas data. And I think in some of them, they said the partners are very willing to share their data. I'm surprised because I've heard from so many other communities that it's hard for partners to trust enough to share their data. So I would like to hear from Tammy and Ted. How did you engage your partners build this trust so they are free, like they're comfortable on sharing their data, especially hospitals and other sites?
Yeah, I wanted to say that earlier, and I never knew if I got quite through all of that, just the importance of partnerships and building those trusted relationships. And that takes time is what it is. I think, you know, if people can see the shared vision, and that's part of kind of that collective impact model that we're all working towards. We all want to serve families better. We all want to be supportive. So we've all got the same end goal in mind. And, you know, just finding, you know, how that data is going to be used, sharing that back, bouncing ideas. And so, yeah, that just takes time to build those relationships. But I think if everyone can see themselves in the work, then that's where the trust goes. But Ted, you might want to add.
No, relationships and defining a common goal are the keys.
Okay, thank you, Ted. And I always joke that everybody should have a Ted in their lives, right? I wanted to name in title. I'm really in a joke mood today, as you can tell. But anyways, I would like to have titled Ted's presentation, TED Talks about data. Anyways, but Ted, on that note, of course, you're so expert in data. We love seeing the tableaus and the data visualization. I know someone asked about Tableau training, because this can be intimidating just looking at all this. How do you learn? Where is the first step that we go to try to play around with Tableau
Sure.
or other data visualization systems?
No,
And
you
what
said
is
the right
Tableau
word.
used for? So we just got a
Well, you said the right word, play around. I do not have any formal training in analytics or IT, that kind of thing. My background is actually in clinical psychology. So it's just playing. And Tableau is very user-friendly. Now, I don't want to be an advertisement just for that. Others on the call may say, well, like Microsoft Power BI is also a good resource or tool. So we don't want to say, they have to use one or the other. But yeah, like Tableau, if you go to tableau.com/learn/training, they have a series of free videos. If a person takes a couple days and views those, they will be able to do some very good things very quickly. Tableau, in terms of licenses, if you're a nonprofit and you're on TechSoup, you can get a 2-year license for something like $75. And again, Tableau itself, the company hosts these visualizations, so you don't have to have the infrastructure. So you can create it, you can put it on their website, then you can link to it from your website, or you can embed it in your website. So you kind of, you come across looking in a good way, like you have all this infrastructure and all these fancy things that, behind the curtain, it's just regular people just working away.
It's just
But happy to visit with anybody about setting these things up, or if anything we can do to help. More than happy to.
Thank you so much, Ted and Tammy. So we have a question here for Brenda. So both Emily and Brenda shared, of course, Tableau is like this modern, newer data systems, but Brenda said the spreadsheet. By the way, Brenda, if you need a name, Emily and I can help you see how the jokes, the spreadsheet, we can brainstorm some titles for your spreadsheet, but even an Excel spreadsheet can be a great start of collecting and reporting. So Brenda, there's a question for you, I think, on how did you get buy-in for the breastfeeding friendly childcare designation? That's great to see how you're measuring how many in your community and all the other data that you're collecting.
Yeah, so that designation is something that our organization bestows. So we kind of own that along with Childcare Aware of Kansas. So because we have this partnership, there's like this free flow of information about where those designations are. As soon as they're designated, both organizations are a part of that designation process. So it hasn't been difficult to know where are the breastfeeding friendly childcare providers.
All right, thank you. And I also love especially the referral metrics that you are asking and collecting. As we know, referrals is like the heart of continuity of care, right? Because without referrals, you don't have the continuity.
That's something that Carmen really was really important that we asked that in that survey. So we worked together on developing those surveys, and that was Carmen's idea. Like, hey, we have to ask about this referral piece for that as well.
Yeah, I mean, when we start creating data metrics for continuity of care, this is definitely gotta be one, right? Not just the referral, but also the follow-up. Did this referral actually happen? So really connecting the dots. So thank you very much. And I have a question here for Shayna too. Shayna, you mentioned, well, I hope everybody joined the call to action to help advocate for this standardizing metrics. But can you tell me a little more about the financial incentives that you mentioned?
Yeah, I think this was a recommendation to look for ways to enact financial incentives for clinics and outpatient settings that are tracking breastfeeding or infant feeding in a consistent way. So there aren't currently any incentives, but this was a recommendation modeled after other quality improvement incentives for other measures that are tracked, and would be a really great recommendation because we know the power of funds to support these efforts. And if there is funding attached to tracking these infant feeding measures, then it's more likely that people will take it a little more seriously and really look into implementing that as well.
Okay, all right. Thank you. And I think there was a question here. The survey, I think that was for you. Is the survey available for sharing?
Yeah, I think they mean that is that for Shayna?
I think it was during Shayna's
Okay.
presentation, but are those surveys available if people want to get started with surveying their local providers, both from you, Shayna and Brenda and Carmen? Are those surveys available anywhere, the templates?
Yeah, for us, the assessments that we originally did with the community health centers, those are available. And I think we still have them on our website. I can drop that in the chat to share.
Okay, thank you, thank you. So some questions for, I'll ask Emily these questions here. How do we involve the community, the community health workforce to understand the importance of breastfeeding and other health measures, and infant mortality is still a challenge. How do you engage everybody to make sure that they understand it's more than a lifestyle choice?
So that's a great question. I would encourage you to peruse the recommendation number 7 in the blueprint, which is really about developing community champions. And when we're talking about engagement, what we're talking about is nurturing relationships. And so it's really important to let relationships emerge. They should never be forced. And what that means is you come at different relationships and conversations from a very honest and transparent place, but you never have an ask when you first go in. It's sharing information and finding a way to make it a win-win. So for instance, breastfeeding has really only been a tidal wave in the public health area, I would say, for approximately the last decade. But the way that we got that foot in the door for many places, whether it was funding, community health workers, pediatricians, this list goes on, was really talking about something that more people cared about. And at that time, it was obesity. Just like in some communities, it might be maternal mortality or infant mortality. And so it's really recognizing that breastfeeding is a spectrum of behaviors that crosses all areas of community and public health. And so you find your edge into what ways you want to have that conversation to make it a win-win and be able to come together.
I just wanted to, can I piggyback off of what Emily just shared?
Of course.
I found a small example of that, Emily, because the survey that was done by Carmen highlighted the electronic health records and their capabilities, right? Like Shayna was saying, to capture breastfeeding data. So we happened to be at a conference where all of these vendors were there and they were exhibiting. And so I literally went down the row and said, do you collect breastfeeding data? Do you collect breastfeeding data? And from that, we had a couple of meetings and they actually showed us like the behind the scenes. I learned a lot. But one of the things that they mentioned about value was, oh, your state has picked, Title V has picked the National Performance Measure number 4 around breastfeeding. Many of our customers are health departments and they need to provide that data back to the state health department. So when they heard that, they were like, oh, we should probably build that in. So we're a more attractive vendor to health departments. Mm-hmm. Just a little story.
Yeah, no, thank you. Thank you so much. I think it kind of segue to Erin's questions here. about, do you think the current Surgeon General would work with us to promote the blueprint and make the recommendation via his office as similar to the 2011 Surgeon General call to action? I think that's, I would just answer just like Emily answered. Recommendation 7 is we need collective work on this, right? So Brenda as a Breastfeeding Coalition, and I think the more we'll talk, the more we make the need the need for this bring more awareness to this. So the blueprint is now in the CDC website as local strategies. So there's several call to actions today to work on the data, on the mandate sharing, the mandate data standardizing. So there's a lot of call to actions here. We will digest everything. We are always giving everything that the community inform us to CDC and then strategize for next year. So we are at time. I just really would like to thank everybody that stayed with us throughout this 90 minutes and to these amazing speakers. Thank you so much for being here. And we will see you next in August, hopefully, during Breastfeeding Month, as we celebrate the 2 years of the blueprint. Thank you so much and have a great afternoon, everybody.